there are two lectures will be presented by Babiker Ismail and Dr. Nadia DR. First lecture will be presented by Dr. Nadia DR, MD consultant pathologist, Soba University Hospital and Royal Care Hospital. The lecture will be about pathological evaluation of complete response and residual tumor following neoadjuvant chemotherapy. You are welcome, Dr. Nadia, and you can start.
Assalamu alaikum. I hope you can hear me clearly.
Yes, we hear you.
عايزين نشوفك يا دكتورة نادية.
كويس لغاية ما أقدر أعمل شير للlecture.
طيب.
Because I have to do it in a certain way. وشاح كيفك؟ I was supposed to share some. Because yes, Wisha, how are you? I was talking earlier. I need to you guide me through the sharing.
أيوة يا دكتورة نادية، كيف حالك؟ إن شاء الله طيبة.
تمام الحمد لله.
يلا يا دكتورة في السكرين ذاته حقة الزوم ابلكيشن. في أيوة في شير تحت. Just click on it.
I did.
Okay. Did it show you that you can share your entire screen?
It doesn't say. Is that okay?
Okay, it's just appearing. Yes,
yeah.
yes, perfect يا دكتورة نادية.
No, because of the link. Is this okay like this?
بس لو عملتي لنا reading view تحت then you can open the link عادي ما بكون في issue. أيوة.
This one.
Yes, yes, this one.
Okay, now it's fine, I think. How about the sound?
It's perfect.
Okay.
Thank you so much.
Okay, thank you. ازيكم كلكم, and it was so good to hear the voice of everybody. Prof. Jaber, and the lovely time we had together. Hopefully it comes back. ميدولين ازيك برضو, it was good to hear you.
أهلين يا دكتورة نادية, how are you?
Alhamdulillah, alhamdulillah, I hope you're fine. And we are all housewives at the moment, which we never did singly. We always were housewives in one of the modalities.
Allah المستعان.
Allah المستعان. I hope we get through it safely.
Alhamdulillah.
And the people at home also. Okay, it was quite impressive, and I know radiology has taken big steps since I studied in university, but I decided with Rehab, thank you Rehab, to take pathology, not going through the details of what we do every day, but actually where I would love it to go, because until now, I think Mr. Omar and Al-Fatih, they know that if there was residual disease, I usually wrote, and I know many reports did not write, R0, R1, and R2. And that was it. But I know that there is a better way of doing it, and some areas are already using it. I'd like to have the feedback from Babiker later, what he's doing there. So the pathological evaluation of complete response and residual tumor in breast cancer following neoadjuvant chemotherapy. So the lecture outline, it's the challenges in the pathological examination of specimens after neoadjuvant chemotherapy, a framework for the gross analysis of post-chemotherapy breast specimens, and the histologic features of tumor bed and post-chemo carcinoma. The second point is to compare some of the available classification systems for tumor burden scoring to highlight the issues and maybe offer some suggestions, because that is what people are doing now, trying to figure this out. Residual cancer
Not clear,
burden.
Dr. Nadia. Your
Yeah?
your voice is not clear. It's very far. Now it's better. Yes.
Like
Can you
this
speak?
is like this is better?
Yes, yes. Like this, it's
Okay.
better.
Okay, keep me posted on that.
Okay.
Residual cancer burden system, and it's the utility and clinical impact of residual tumor burden. And the last one is to understand the reporting schemes and the essential elements to be included in the pathology report. Now, pathologic complete response. So it's a measure of the success of neoadjuvant chemotherapy is pathologic complete response. It's a measure of that. So I've now had your input from radiology, and that was very interesting. And radiology being a non-invasive technique, I can only do it on a specimen. And usually my specimen would be a resection by a surgeon after neoadjuvant chemotherapy. So I can only report on the specimen. Now I have realized that in radiology, you can evaluate the whole patient and you actually can have the patient with you. For me, I have a specimen in a container. So it's defined as the absence of residual invasive cancer in the breast and in the lymph nodes after completion of neoadjuvant chemotherapy, and its completion, because this when the oncologists decide now we go for surgery. As an increasing number of breast cancer patients are treated with this, pathologic evaluation has become critical to determine an accurate prognosis. There are multiple classification systems that have been developed to assess treatment response, but these differ with respect to the number of response categories, the determination of tumor size and cellularity, inclusion of in situ carcinoma, that's a big issue, and
Voice is
assessment.
not clear again, Dr. Nadia.
I'm in the same position. It will only be the net.
It comes and goes. It's very far.
I'm in this, okay. Assessment of response in
Now
lymph.
better.
Despite the differences, however, tumor response in each system has been shown to correlate with outcome. So this makes the trouble we go through important, how we classify and which classification we use. This is the Nile for everybody out there in Jeref, and the photo was when we had flooding. It was coming into the garden. Hopefully we can go back. Now, the steps to evaluate a post-chemotherapy breast biopsy, regardless of what type of biopsy it is. So first of all, we have to recognize it is post-chemotherapy. And then identify gross tumor bed, and document the size. Judiciously sample and make a map of those samples we took. Assess residual size, the largest contiguous area and span, and then the cellularity and the standard parameters. Evaluate lymph nodes. Report as per the local custom or mandate or guideline. Now, in the neoadjuvant chemotherapy setting, or we should say in the post, the interpretation of the basic parameters such as tumor size, the grade of the tumor, and the lymph node involvement can be a big challenge, can be very challenging for pathologists because of therapy-related changes. Identifying the tumor bed. Let's take them one by one. Now, general term, fibrous tumor bed or tumor bed area refers to the grossly or radiologically identifiable area of breast parenchyma where the tumor was located before the initiation of systemic treatment. According to the response to therapy, the tumor bed can be easily visualized or only by correlating with pre-treatment radiology records and clips. So X-raying the tissue is one of the things that we need to do to identify the tumor. Could be the only way. Careful palpation of the slices. When we receive the specimen, we slice it. So careful palpation of specimen slices is very important. So it's actually that we recognize the area by touching it rather than and feeling it rather than by seeing it. A detailed description of the pre-treatment tumor location, the quadrant, the distance from the nipple, whatever makes it, and then or sutures placed by the surgeon. Microscopic proof of the tumor. Sometimes we have to take this last step. We just go, we cannot see anything, we cannot feel anything, and then in the end, we take samples from what we think is the tumor bed, and it turns out to be or not to be, and then we go back. Now, an accurate identification of the original tumor bed in a breast specimen is the most important step because that's where you're going, supposedly, that's where you need to take your tissue blocks. Because another thing that is different from radiology here is that I have a specimen, and in this specimen, and I have to find it. I cannot go to other areas. Of course, the surgery itself is guided by the radiologist that has seen the whole area. So especially this is when it's not a mastectomy, when we have breast preserving surgery. So this is the pre-treatment tumor. This is breast tissue, and that's the tumor in it. Now, what happens in therapy? Either no response, so that in the time period where the patient is receiving treatment, the tumor is increasing in size. You can have a partial response, which could be any one of these. And you can have complete response where the tumor bed is now only fibrous tissue. So it depends. This makes detection of the tumor bed in a specimen sometimes really difficult. So how do I sample? If I have a small specimen, I submit entirely. I'm in this slide, we're making very, very short. Small specimens are submitted entirely, and of course you have to map it. Large specimens, you are guided by the pre-treatment size and location, and you map. Multiple pre-treatment lesions, you go as above, and you sample, and you sort of treat each lesion by itself. And I put this here in red because good clinical judgment on a case-by-case basis. And I think this applies to all the questions we had before. You must have a system, of course, you have to have guidelines, but in the end, good clinical judgment on a case-by-case basis. Each case is different. In more details, the sampling of the tumor bed, if the residual tumor bed is small, less than 3 centimeters, the entire fibrous area should be submitted for pathological examination. If there is an obvious tumor bed on cross-examination that is large, more than 3 centimeters, you take 1 section per centimeter of the pre-treatment carcinoma size. That is a guideline, and that's reasonable. But again, your clinical sense will tell you what to do. You might have to take more sections. An important objective is to map out a complete cross-section of the tumor bed along its longest axis, because residual carcinoma could be present in any region of the tumor bed. So that's where the clinical sense in and the clinical information, of course. Additional tissue as needed according to characteristics of the tumor. Sometimes that's very important, the characteristic of the tumor, because We have some tumors that are sort of single mass and staying together. We have tumors that are dispersed all around. Clinical information, including response to treatment. That's also very important. What was how many investigations were done, radiological investigations, to see how did the tumor shrink, clinically and radiologically. Now let's get to some photos because this was a lot of talking. This is a mastectomy specimen. And you can see there's a clip here on the nipple. And I think we have a stitch here. So a mastectomy with a clip at 12 o'clock and a stitch in the axillary tail. We need to know the location, size of the pre-chemotherapy cancer or cancers, and any additional lesion on imaging. What we do, as we said, we do slicing of this whole specimen. And you can see this is the lateral, medial, and you have to put the slices. The color you see here is inking. We take a section from the nipple and we ink the specimen. We can use different colors or we can use one color, but we agree on it. It's a lab protocol. Availability of multiple colors makes it, of course, easier. So if I use black for the deep margin, I can use a different color for the superior margin, inferior margin, and lab protocol. And mapping of the sections, I think I have it in the next one, is like this, because I took a photo and then I know. I took a slide. I made one of slide number 3 from this area. I know it is from my section 25. 6, 5, 4. I map exactly. This is where the tumor is. So this is where I make my mapping and I take most of the section. This is important because of the way I will later calculate the amount of remaining tumor to give it a score. Because as I said, we are trying, this is a method of doing it in a more scientific way that correlates. Sometimes I need to make sure by X-ray, I can X-ray the slices and make sure that I'm getting the tumor, the remnant tumor or the tumor bed. So this one is like a summary. We grossly identify the fibrous tumor bed. You can see this constricted area here. This one is larger. Specimen radiograph of a partial mastectomy with 2 separate tumors and corresponding biopsy clips. And then the coloring and the mapping out of the slices and where the samples for slides were taken. And always remember that the clip or the radioactive seed was inserted in this case for identification of the post-therapy lesion. Now, all of this, I think it gives you the importance of a properly filled request form and the information from the multidisciplinary team meeting, because this is for me pre-analytical information. And it's important for the grossing pathologist, I should put here /technologist, to have the information regarding the number, size, and location of tumors and the biopsy clip and any involvement of the skin, chest wall, or nipple before treatment, and any documented response to therapy on clinical notes and imaging studies. I cannot emphasize the importance of this. If a pathologist goes into the grossing room without knowing what the specimen is about and what the clinician or treating unit is requesting from you, I cannot give it to him because it was not stated. Now, once we have prepared our slides from those areas, then the tumor breadth is characterized on microscopy by irregular area of vascularized fibrous tissue that either lacks or has scant normal ducts and lobules, breast lobules. The stroma may exhibit varying degrees of edema, myxoid change, fibrosis with or without elastosis, residual calcification, and inflammatory cells. The inflammatory response typically contains lymphocytes, plasma cells, mast cells, macrophages, and hemosiderin-laden macrophages. Calcifications and extracellular mucin associated with carcinoma do not resolve in the breast or in the metastatic sites after neoadjuvant chemotherapy. So they will still be there. But they help us in identifying this is the tumor. The most common therapy-related change is decrease in cellularity, increased cytoplasmic vacuolization and eosinophilia, pleomorphic and bizarre nuclei, and decreased mitotic activity. These are things we find in the tumor cells. They make the tumor cells different, look different, but still recognizable, sometimes not. Prominent stromal retraction artifact around the tumor nests are common and should not be misinterpreted as lymphatic or vascular invasion. Residual single tumor cells in cases with near complete response can be difficult to discern from inflammatory cells on routine hematoxylin eosin stain, and in cases like this we can use immunohistochemical stains for cytoperatin to delineate the distribution of tumor cells. Now for some photos. Now this is a low power. You can see this is breast tissue, and this is the tumor bed. This one, 6, shows the tumor bed of a high-grade mucinous carcinoma with complete response to neoadjuvant chemotherapy, but you can see the remnants of the extracellular mucin. In 7, you can see cellular changes in residual tumor, and you can see how the tumor can change and become very bizarre in shape. The pre-treatment tumor did not look like this. These bizarre changes are due to the treatment. This is normal breast, and this is the edge of a tumor bed in the same specimen. So this is normal breast tissue, maybe a bit atrophic from the changes, but in this case, you can see here are some tumor or some glandular tissue, I should say, not to become too specific, but you can see how fibrous and low cellularity is the main thing that happens after treatment. Now, in this case, it looks a bit more cellular. The pinkish areas are the fibrous tissue, and you can see these are cells. And one would take the idea that this is quite cellular. You said low cellularity. But when we look at these cells, they are histiocytes. And these are reactive in the area of the tumor bed, denoting the reaction to injury. Breast parenchyma, a bit atrophic. This is a breast lobule. These are ducts bleeding out. But you can see post-chemotherapy, there is some atrophy. And in this one, you can see the reactive changes. Again, we have the foamy macrophages. We have some calcification here. We have multinucleated giant cells. And we have the areas where we have the multinucleated giant cells are actually engulfing crystals that have washed out with the processing of tissue. And all of these are reactive changes post-chemotherapy. More tumor bed sections. Hardly any lobules, just fibrous tissue, vascularity, and low cellularity. In carcinoma, The carcinoma was attacked by the treatment, and we have changes. We have histiocytoid appearance, cytoplasmic vacuolization and eosinophilia, nuclear hyperchromasia, pleomorphism, decreased mitotic activity, lobular-like growth pattern is the distribution of the cells, the distribution of the remnant tumor cells, and heterogeneity, and that is selection by chemo. Some of the tumor remains because it's not affected by the treatment. Residual tumor bed, this one is not completely free. We don't have complete response because when you go on high power, you see these small clusters of cells. And this is remnant tumor. Now, this one could practically be a histiocyte, but we have to make sure, is this residual invasive carcinoma or are these histiocytes? On immunohistochemistry, they take the cytokeratin stain, and we have the proof that this is remnant tumor cells. I just want to show how difficult it is, because this picture shows a DCIS. Life is not always easy, no? For DCIS is one of the features that we need to look for in every case of, and we need to grade it also. And we need to include it in the report, and it's part of the calculation. Another thing that is very helpful is to have the diagnostic core or needle biopsy, because the changes that you can compare, and this is the same one after treatment, you can see the changes that have happened. You don't have them here. Nuclear changes that have happened, these are reactive post-chemo. And you can see that there has been response, but it's not a complete response. Now, determining residual tumor size can be difficult after treatment. It's easier to determine the size of the residual carcinoma when the tumor shrinks, of course, concentrically, leaving one contiguous focus, an uncommon scenario. Most treated tumors with moderate marked response to therapy leave scattered nodules of residual tumor, multiple clusters, or single tumor cells in the tumor bed. So this is one of the studies that has led up to the system of, I think that should be more accepted. Hopefully it will eventually be taken up, that it should be in the standardized reports, a standardized report of these breast samples. So you have, yes, you have, this is breast tissue, normal breast tissue. This is the tumor, and this is how we start. But then how does it go back? How does it react to treatment? So the microscopic tumor bed, and this is the tumor bed, and there is decreased cellularity. This is the tumor bed, this is the remnant. This is the tumor bed, and you see the scattering is irregular. Here the tumor bed has become smaller. Here it has not, but the cellularity is less. And then the distribution of the cellularity. So we still measure this as the tumor bed. But then we have to give a figure to the cellularity and how it is distributed. So residual tumor.
Nadia,
Yeah.
you have 5 minutes
Then
to
I'll have
finish. Okay.
Yeah, I guess you'll have to give me a 5 more, if possible.
Just try to go as fast
Yeah,
as
I'll
possible.
go quicker. I'll go quicker.
Thank you.
Okay, so this shows you this is a nodule of remnant tumor, residual tumor. Here we have multiple nodules, and here we have much smaller areas of different distribution of cluster beds. This point I have anyway summarized, just it could be a whole lecture by itself, is the estimation of the metastatic carcinoma in lymph nodes and its detection after therapy. And in this case, sometimes, again, immunohistochemistry might be needed to detect it. Now, the prognostic information from the degree of the pathologic response is the measurement of this residual tumor burden to predict survival. And it depends on this. It's a proposed system of residual cancer burden as a continuous variable depending on primary tumor dimension, residual cellularity, and axillary nodal burden. Typically, the cellularity assessment is identified to the nearest 10%, and the usual understanding is to make estimates only in foci of the tumor bed that contain significant residual tumor. The estimates should represent the average across the entire area of residual invasive cancer, not the most concentrated foci. So the pattern of residual, we said it varies. So how you evaluate each one and where you evaluate it is very important and can make life very difficult. Now, in one slide, you have the residual cancer burden, sample mapping and counting with evaluation. So this one was the tumor, the residual bed. We need, first of all, to measure it. Then we take sections by number. Then we have the slides. And in each slide you have to give a percentage. You can use 1%, but usually it is abbreviated to 10%. Each slide is given its value of the whole tumor bed. Then you give an overall, and this number with the estimation in your sample of the carcinoma in situ, DCIS, will give you a calculator that is used by the MD Anderson Cancer Center, residual cancer burden calculator. These values that you determine, you need to put into this, and you can calculate by I just went online, you calculate, and then you have residual cancer burden with the class. It's given automatically. I have included a link. Yeah. Naima, I think I need your help to get back.
أيوة يا دكتورة نادية.
I need your help to get back from my link.
Your link is not obvious for us. It's the screen of your slideshow.
Okay, then it didn't.
So I think, yes,
You are
yes.
Yes?
So I think you have to stop sharing your screen and then let your entire screen to be shared so that we can see the link with you.
I only have a short time to go on. Let me continue. So in another system that is used is the American Joint Committee on Cancer staging system. In its 8th edition now, and for the first time, it is integrating the anatomic stage data with other prognostic factors such as histologic grade, ER, PR, and HER2 status. And another thing is that establishes the post-neoadjuvant therapy clinical TNM classification, this is important, and pathological TNM classification, including examination of primary tumor, lymph nodes, and any metastatic foci. We hope that in the new classifications, more details will be given. Now, only the largest contiguous focus has a modifier of n if we have multiple foci. And I think it needs to be made clear, not depending on subjective how or different systems, how to measure this, the largest tumor when you have multiple patches of fibrosis in between. Now, the last point is the elements to be included in the pathology report of treated breast cancer. We have the breast specimens, lymph nodes, and the classification of neotherapy response. So in pathological complete response cases, microscopic confirmation of the tumor bed without residual invasive tumor should be mentioned. This should be very clearly mentioned. The tumor bed dimension may be omitted to prevent misinterpretation of tumor bed fibrosis as residual tumor. Two-dimensional microscopic measurement of the largest area of invasive cancer, the cellularity of the residual cancer as a percentage of the area involved by invasive cancer, histologic grade of residual tumor unless distorted by treatment-related change, presence of lymphovascular invasion, presence and extent of DCIS, margins with respect to residual invasive carcinoma and DCIS, mention of the tumor bed at the margin in non-pathological complete response cases, retesting of tumor biomarkers if applicable, Ki-67, and presence of tumor infiltrating lymphocytes in the tumor bed. We continue with the lymph nodes, the number of the lymph nodes with metastasis and treatment-related changes if present. Usually, lymph node evaluation is really difficult. Even it's difficult in grossing that you get the lymph nodes. Size of the largest metastasis, presence of extranodal extension and the extent, the widest diameter of the invasive front, number of lymph nodes with definite evidence of treatment response but without tumor cells. And the third point is the classification of response to treatment, either according to the AJCC or the residual cancer burden system.
Dr. Nadia,
I just lost my screen.
your time is over.
Just, Dr. Khalid, we can just let her to conclude.
Okay.
I have just my last slides, like I lost the screen. I cannot go back to. It's sorry.
Can you
No
try
problem.
to unshare and share again?
Is that okay? Can you see it now?
Yes, yes, we
Okay,
can see it.
fine. Maybe I will drop this point because I was going to talk about retesting of tumor biomarkers because of tumor heterogeneity. Anyway, the conclusion is a pressing need is to develop a post-neoadjuvant synoptic report format relevant to reporting residual disease after neoadjuvant therapy, and artificial intelligence is being incorporated in many aspects, also to evaluate treated breast cancers to standardize reporting and search for prognostic and predictive factors. And I think this will generate a lot of literature that will influence it in the next in the next period. Every pathology practice should implement a standard operating procedure for collecting, handling, and interpreting pathology specimens treated with NAT as for all cases, for all pathology cases. And standardized reporting is the most important in getting the first step for multidisciplinary teams, because if I don't have a standardized report, I cannot join a multidisciplinary team. These are my references. The last one is the one I think you can check, because this is the one that didn't work now, and we'll explain it. Thank you. We are all stronger together, definitely, and that's why I'm again for multidisciplinary teams. And thank you. Hopefully we can do it over next months.
Thank you very much, Dr. Nadia.
شكرا لك, Khalid.
It's nice and informative lecture, actually.
I hope you got a lot of it, because it's pathology.
Thanks.
Usually people are scared of
Okay, our next speaker is Dr. Babiker.
Tell me how to unshare so I can allow you to proceed.
There is a stop button, stop share button. Okay, yes, you did.
Yes, okay.
Thank you.
Babiker ازيك?
Dr. Babiker.
Alec,
Okay, so our
thank
next.
you very much for the nice talk.
Thank you.
Thank
The
you.
talk will be about prognostic indicators of breast carcinoma. Will be presented by Dr. Babiker Ismail. He's a senior consultant histopathologist. He has MBBS, University of Khartoum, MD in clinical pathology, University of Khartoum, MRC Bath, and FRC Bath, Royal College of Pathologists, UK. CCST is the Joint Academy of the Royal Colleges, UK, and he is specialized in oncological histopathology. He's now working in Oman University Medical Center, Sultan Qaboos Comprehensive Cancer Care and Research Center in Sultanate of Oman from 2022 up to date.
Thank you very much, Khalid.
Babiker, you're welcome.
I'm very pleased to be with you here, with our country facing very difficult time. And my salute to all martyrs in East Al Jazeera, in Tambol, all over the Sudan. And we hope the third symposium will be held in Sudan, inshallah, all together. Actually, I have been asked by your coordinators to talk in this high-profile meeting. And actually, I didn't know exactly how to approach that, but now I am approaching it from the way that we approach each pathology specimen. We don't discriminate whether it is a locally advanced or whether it is a micro cancer or whether it is a benign. We deal with all specimens equally. So I have picked some aspects that might be of interest to you in your theme, which is the locally advanced breast cancer. I'm going to start that with the prognostic indicators of breast carcinoma. And let me just try to get rid of this ribbon. Sorry, I didn't get that. Are you? Do you see the screen now?
Yes, we can see your screen. لكن ممكن تعمل لنا ال reading view عشان نشوفها full screen.
All right.
جنب السلايد شير في open book icon.
Just a moment. Yes, it disappears from me here. Let me. Right.
هو في نهاية الشاشة جنب comments والحتة بتاعت السلايد شير في open book icon. So if you press on it حنشوف one slide at a time.
Okay, just a moment. I'm not used to this MacBook. Right. Okay. So this is. I think this is a reading view. No, is it this one?
Yes, yes, this one.
This one.
Yes, thank you.
Right. So I'm going to talk about the role of biomarkers in breast cancer, and we've got about 5 biomarkers. Estrogen is very well known, and it is related to the anti-estrogen treatment. Progesterone is complementary to estrogen, and then we have the human epidermal growth factor, which is HER2, and now we have got the anti-HER2 treatment. Ki-67 is a proliferation marker, and it gives a very good idea about the prognosis. When we have a triple negative breast cancer, then we resort to do the PD-L1. So the breast cancer is classified generally into luminal A, which is ER/PR positive, HER2 negative, and low Ki-67, and luminal B, which is ER/PR positive, HER2 negative or positive, and high Ki-67. So luminal B is prognostically is a higher grade. Then there is high HER2 enriched, and there is basal-like, which is often triple negative breast cancer. And as you know, the subtyping of this tumor, which we do on biopsy, the initial biopsy, Dr. Khalid, that we have talked about earlier, we prefer to do these markers on the biopsy because it will be very optimally fixed, not like the larger specimens. So that will help us to predict the prognosis, and then according to the prognosis, the tumor could either go each way, including the locally aggressive. The biomarkers assist in diagnosis and also provide prognostic information and predict therapeutic options, as I have said. Then the variability in interpretation of staining. This is one of the issues that we should have in mind, and also the inter-laboratory interpretation of the immunohistochemistry result. And the third issue is the HER2 2 pluses category, which we normally proceed with doing FISH to assess whether this is a positive or a negative HER2. The estrogen receptors are found in about 70% of breast cancers, and these respond well to hormonal therapies, and the immunohistochemistry is helping us with that. It is a nuclear positivity. In histology, we prefer always the nuclear positivity because this is very crispy and it can help us to pick it up quite easily, unlike the cytoplasm, because there are a lot of issues that relate to cytoplasm. And regarding the ER, there are score systems which are used. The UK one, which is most commonly used, is the already score system, which is 0 to 8. And the American, the CAB protocols, they just have a cutoff point at 10% as a cutoff point for positivity, and they consider 1 to 10% is a low positivity. The ORED is a bit comprehensive because this is the estrogen and its molecular representation. The ORED score, this is the American where they use the percentages. Now using that, I used to use the British one when I was in UK, but now we are adopting the CAP protocol, as in most of Gulf countries. They prefer to follow the Americans. So the already score, it does two things. It is scores for intensity. So when there is no staining at all, this is 0. When it is weak, it is 1. When it is moderate, it's 2. And when it is strong, is 3. And then it also incorporates the percentages. It is 1 when it is 1% or less than 1% of the tumor. And then it goes up to 5, which is 67 to 100%. So a combined score, for instance, a tumor which is 70% or 80% positive with a strong staining, this is an 8/8 already score. I think this is more logical, but eventually the two systems work close by because in the American CAB approved protocols, I don't think they consider the weak staining, so they consider the moderate and strong, which is 2 and 3. And the cutoff point is 10%. So if it is more than 10, that the score in the already is 11 to 33 is 3. And then if we take 2, is 5. 5 is positive, and below 5 in UK system, 4 and below, they consider it as negative. So more or less, the two systems are comparable, and the eventual result is similar. It is easier to do it the American way because you just put the percentage, but it is more logical to do it the British way. The ER positive status is associated with favorable survival rates in breast cancer. And the tumor should be here low proliferation to have a positive or a favorable survival rate. There is a category which is 1 to 10%, which is they consider it as low positive. This one is comparable if there is a high proliferation fraction, is comparable to the triple negative breast cancer. This is just a picture to show the staining of ER. On your right-hand side, this is a lobular carcinoma with 8/8, which is 100% positive estrogen. And as you could see, the antibody of the immuno is targeting only the nuclei. And it is the same tumor on the left side, which is a lobular carcinoma. And this one is 100%. The cells which look gray in the middle, these are stromal cells, which may not stain for the estrogen. This is ER in DCIS. As you could see here, there is no invasive tumor. These cribriform formations of the pre-invasive state. The staining is nuclear. As you could see, the deep brown color, while the nuclei are taking the light brown, sorry, the cytoplasm is taking the light brown color. In DCIS also, we take an advantage of that. Sometimes some of the DCIS cases or some of the borderline cases that we are not sure whether DCIS or not, also we test them by ER, and DCIS is a clonal disease. So either you find all the cells are positive or all of them are negative, and that will tell you this is a DCIS. This is not an ADH, for instance, or just hyperplasia. So it has got another use in DCIS. Normally, we don't benefit from that as a prognostic for cancer. I mean, measuring DCIS estrogen receptors. This is just out of the topic, just to show a benign breast on the right, H&E. And you see the pattern of the ER in the benign breast lobules. As you could see, this is not a clonal phenomenon. Some of the cells are positive, some of them are negative. So this is just a benign tissue. The progesterone is more or less like estrogen, and also it is scored by the same already score, and it has got the same cutoff point of 10% in the CAB protocols. Then we move to HER2, which is another prognostic indicator of breast cancer. It is amplified in 15 to 20% of breast cancers. And when it is amplified, that means it is an aggressive tumor. But however, thank God that we have got the anti-HER2, the trastuzumab, and that will hopefully sort out the issue. The immunohistochemistry is used to score HER2 expression, and it is very guided. Also, the ER and PR also, They are monitored by external quality schemes. Every 3 or 4 months, we get slides on ER, on HER2, to grade them for the scores that are according to the CAP protocol, and then submit the results, and then you have to get specific degree of concordance. So these are externally monitored in EQA, and I think same protocol is done in UK as well. The HER2 gene amplification and protein overexpression, it drives cancer. It has got a link with a lot of other tumor drivers, and it is an important prognostic and predictive biomarker in breast cancer. The gene encodes the HER2 is a transmembrane growth factor receptor that regulates cell growth and survival. I think there is a lot of biology in relation to HER2 that you could elaborate on that in further studies. I'm not going to get into depth into this. And the pathophysiology that the HER2 is not only working on itself, also it can activate signaling, multiple major signaling pathways, RAS and RAP, MEK, etc. So it is a RAS guide in the cancer. And it prohibits the apoptosis and promote the cellular proliferation. HER2 also can drive the breast cancer progression. The clinical feature, it is overexpressed in according to the Journal of Clinical Oncology, 2023, about 15% of breast tumor, and overexpressed in 30% of ductal carcinomas in situ, DCIS. But we don't know what is the prognostic importance of this fact. The prognostic biomarker is associated with higher grade of histology and histologic grade with advanced stage and also with brain and visceral organ metastasis. So it is not only locally advanced, but it can also lead to spread of the tumor. We measure HER2 also in some other cancers, non-breast cancers, gastric, and the grading and the scoring is different between the gastric and the breast carcinoma. And the immunity detects evidence of protein overexpression by evaluating the membranous staining. So it is membranous stain. I'm going to show you some pictures of the HER2. The HER2 testing must be performed on every primary invasive breast carcinoma, and also should be repeated on metastatic and if it recurs as well. As I have said earlier, the biopsies are affected by other non-interpretational issues in relation to the formalin fixation time and other processing environment. So the needle biopsies and resection specimen can be used for testing and also cytology specimens, but cytology should be a bit adequate. You cannot do it in less than 100 cells in FNA cytology. The tissue should be carefully fixed, 10% neutral buffered formalin between 6 and 72 hours. If overfixation occurred due to coming in Christmas Eve and staying for 3-4 days, that might affect the interpretation of the immuno. So these are very critical, and a biomedical scientist should come during the holiday season to try to sort out these issues. As I have said earlier, each lab which deals with HER2, should have a 95% concordance in their EQA result with another validated test. As I said, we do that now with the College of American Pathologists. The HER2 assessment is not validated in decalcified specimens. So if the tumor is having some osteoblastic proliferation and some or in bone marrows or in bone, it will be very difficult to have a reliable result on HER2. The guidelines for interpretation, these are monitored by College of American Pathologists and Association of Clinical American Society of Clinical Oncologists. As I said, we measure HER2 also in gastroesophageal junctions using different criteria. And in the breast, only the membranous reactivity on the invasive tumor cell is counted towards scoring. And any expression in the DCIS is ignored. Also, if there is cytoplasmic reactivity, it is ignored. So the only score which is considered positive is when it is 3 pluses. And the tumor is 3 pluses when the membranous staining is complete, intense, circumferential, in more than 10% of tumor cells. The equivocal score 2, which is 2 pluses, is weak to moderate complete membranous staining observed in more than 10% of invasive tumor cells. This is the most famous one. And other scenarios also regarding the 2 plus category are there. So score 1 is negative, although it is 1 plus, but it is a negative score because there is incomplete faint membrane staining and within more than 10% of invasive. If it is less than 10%, it is a score 0. If there are any issues related to the specimen, whether it is a crushed artifact or analytical testing failures, etc., the result should be indeterminate. It shouldn't be given any score, and the test should be repeated in different specimens. For score 2 pluses, which is the equivocal one, we proceed to FISH scoring and do the dual probe HER2. If the ratio is more than 2 with average HER2 copy numbers more than 4, this is positive. If less than 4, it is negative. The patient is considered HER2 positive if HER2 immunohistochemistry score is 3 pluses, or if it is 2 pluses with positive FISH, or HER2 ish is positive in regard of the immunohistochemistry result. And it is negative if it is immunohistochemistry 0 or 1 plus, or if it is a score 2 pluses and the FISH is negative. So there are some few words about the FISH here, but sometimes they give the benefit of doubt so that if the immunohistochemistry score 1 plus, and that is the importance of 1 and 2 here, and even the FISH is non-amplified, this is, they call it HER2 low status, and there are some consequences that we will come to that later. As I said, HER2 is a prognostic and predictive biomarker used to identify patients with HER2 positive breast cancers that are most likely to respond to anti-HER2 therapy. Patient with unresectable or metastatic breast cancer that is immunohistochemically shows a score 1 or 2, HER2, FISH not amplified, or having low expression, who received prior chemotherapy in metastatic setting or recurrent within 6 months of completing adjuvant chemotherapy, are also eligible for anti-HER2 treatment, despite that it is 1+ or 2+. So that the benefit of having 1+ or 2+ in this scenario that will qualify you to have anti-HER2 treatment. And I think our oncologists here also could advise on this issue, whether this is practiced in Sudan and Egypt or not. Also the anti-HER2 therapies will help to reduce the recurrence, metastasis, and mortality only in HER2 positive breast cancer patients. Anti-HER2 therapy improve the survival in patients with HER2 positive metastatic disease. So it is very crucial to give the exact score. I'm showing here two scores. On the left, I have got the 1+ score, which is more than 10% of the tumor shown here is showing staining intensity, which is on the membrane. Ignore the cytoplasmic intensity. Most of these are membranous, maybe 1 or 2 cells showing cytoplasmic. And the membrane reactivity is, as you could see here, is not circumferential. It is partial or incomplete. The other trick that we use, we need to see this. This is not easily seen. This image that you see here, it is either seen by ×20 or ×40. So anything that is not seen by low power is not a 1+. The 2+ on the right, more positivity, more staining, as you could see, in more than 10% for, but HER2 is still weak to moderate. And in this case, it is detected by ×10. As you could see here, the cells look a bit smaller than the ones on the right. And there is complete circumferential membrane reactivity, but it is either weak or moderate, and it should be in more than 10%. In the categories used in the GI, any percent, they don't limit to 10%. And this is the 3+, as you could see, is a crystal clear, membranous, and this you could see it by ×2 or ×5 by a low bar. So this is one of the ways that we could tell this is a 3+, just from the low power view. The HER2 positive staining disease, it is 12 to 20% positivity in no special type of adenocarcinomas, and it is 20 to 30% in invasive pleomorphic lobular carcinoma. It is higher expression in pleomorphic lobular, not the standard lobular with the Indian filing. The negative staining in the breast in HER2 could be seen in the low-grade invasive ductal carcinoma, NST, which is no special type, in tubular carcinoma, in mucinous carcinoma, in invasive lobular carcinoma, which is classic type, not the pleomorphic, in cribriform carcinoma in less than 5%, metaplastic carcinoma, adenoid cystic carcinoma, secretory carcinoma, mucoepidermoid carcinoma, tall cell with reverse polarity, and neuroendocrine tumor and carcinoma. Then we move to Ki-67, which is another prognostic indicator in the breast pathology. And Ki-67 measures the cell proliferation rate. When it is high, it is associated with aggressive cancers, either locally or metastatic. And also it is used as a prognostic marker and to assess therapy response. The Ki-67 is a cellular proliferation marker that is reported normally in percentages. It is low in benign tumors, in luminal A carcinomas, and low-grade carcinomas. It is high in high-grade carcinomas, triple-negative breast carcinomas, HER2 positive carcinomas, and luminal B carcinomas. It is a very effective independent prognostic marker to predict disease-free survival, to predict the overall survival and complete pathologic response to new adjuvant chemotherapy, as Nadia has told you previously. Also, it is associated with low inter-laboratory reproducibility and higher inter-observer variability. It's subjective at the end, but in good hands, it is a safe thing. K67 in ER a positive, HER2 negative. T is either T1 or 2, and N0 patient is prognostic. With Ki67 5% in these scenarios is low, and Ki67 more than 30% considered high if the tumor satisfies these features, which is either it is a T1 or T2 tumor and ER positive, HER2 negative. And it is an independent prognostic marker to predict free survival, overall survival, and complete pathologic response to new adjuvant therapy, as I have said earlier. The prognostic factor in early stage, I think this is just a repetition of the same thing we have said before. And this is,
Babiker,
yes,
5 minutes remain.
sure, no problem. On the right, this is the Ki67, which is a high expression, almost 90%, and low expression on the left. The triple negative breast cancer is problematic when you have got negative ER, HER2, then and PR. Then we resort to do the PDL1 and immunotherapy. The PDL1, the clone which we use in our lab is 22C3 clone. It is an FDA-approved companion, and it is diagnostic to pembrolizumab in certain clinical scenarios, including the triple-negative breast cancer and other diseases as well. I have just included 2 talks about inflammatory breast carcinoma and Paget's disease of the breast. I'm going to go through this very quickly. The inflammatory breast carcinoma, the onset is very rapid, and it is in large and edematous breast due to dermal plugging of lymphatic vessels by tumor. It is very rare, 2 to 5% of all newly diagnosed breast cancers, and we need to diagnose it by 2 skin punch biopsies. The previous studies have reported poor survival rates. However, this may be due to advanced stage when we diagnose this the inflammatory breast carcinoma, i.e. that the poor prognosis is related to delayed diagnosis. And the similar cancer specific survival in patients with inflammatory breast cancer and stage 2 for non-inflammatory breast cancer. So that is its specific survival. The use of neoadjuvant therapy has improved survival rates. 50% of patients with complete pathological response will subsequently recur due to a lot of infiltration of blood vessels, and this is how it looks. I'm sure you have seen that. Paget's disease of the nipple, it could be associated with a mass or with no mass. When it is not associated with mass, the prognosis is very good, 95% survival at 20 years. If it is associated with mass, then the survival will be related to the mass and its features. The prognostic and predictive factors after new adjuvant therapy, I think Nadia has talked about that. I'm not going to mention it. This is the mastectomy. There's different types of mastectomy and the indication of mastectomies. I'm not going to go through that. I'll just touch slightly into the TNM staging, which Nadia has mentioned about that and gave you a good account on that. The new things, as Nadia have said, that in T1, so it is a micro cancer if it is less than 1 millimeter. And thank you for the highly advanced radiology and imaging techniques, which can detect now tumors less than 1 millimeter. I myself, I have seen such similar tiny tumors. And then there are some small subcategories. You could go and check about that. Also, the any stage has got a lot of now subcategories, and they use reverse transcriptase PCR in also in this TNM staging. Just very briefly, the histologic grade, which is, if we cannot assess the histologic grade, this is a GX. If it is a low grade, that is score 3 to 5, and intermediate 6 to 7, and high grade, which is grade 3, is 8 to 9. Basically, we combine 3 features of the tumor: the formation of the glands, the pleomorphism, and the mitosis. And each one has got from 1 to 3. So the low grade, only 3 to 5, then 6 to 7, then 8 to 9. 9, that means low tubules, less than 10% or absent, very pleomorphic. The size of the nuclei are very big, vesicular nuclei, prominent nucleoli, etc., and a lot of mitotic activity. There is something called the Nottingham Prognostic Index that is used by the British people. They love it. It is basically 0.2 times the size of the tumor plus the node, number of nodes involved, plus the grade of the tumor. And then it is a numerical thing, and then you follow the same thing, and that will give you the prognosis. So it's doing the same thing in a different way. The last thing that I want to mention is the breast cancer mimickers. If there is no response to treatment, then we should think this could, the mimicker, they mimic the triple negative breast cancers. So oncologists and surgeons should think about this possibility, and they can be sorted by immune histochemistry. Diffuse large B-cell lymphoma, I have seen that before in the breast. Metastatic malignant melanoma, I have seen that as well, and it looks very quite similar to grade 3 invasive ductal carcinoma, NST. Also metastatic carcinomas from different places like lung adenocarcinoma, endometrioid adenocarcinoma, serous carcinoma, and renal carcinomas. And also ductal carcinoma in DCIS in lesions like sclerosing adenosis. That makes life very difficult. Even sarcoma could also be one of the mimickers. For pathologists, they know how to solve this issue. Mainly the breast marker CK7, GATA3, and ER, etc. will sort the issue with LCA and S100. And that is the end. Thank you very much.
Thank you very much, Dr. Babiker, and also thank you very much, Dr. Nadia, for these comprehensive and informative lectures about pathology. And really, I was thinking that pathology is much easier, and I was thinking always that the life of the pathologist is easy. Not like us, but I came to understand that your life is also difficult, and you have many difficulties and many struggling also. So thank you very much for your participation, and we can delay the discussion for the end of the day, inshallah. And I want to welcome Dr. Arwa, who has joined just now. She was supposed to moderate the pathology section, but she was in a journey, but now she catched us, and she will lead the discussion at the end of the day, inshallah. Now we came to our last session in this day, which is a case presentation, which will be conducted by Dr. Rayyan Jamal Hamid. Dr. Rayyan is a medical doctor working at Riyadh in Saudi Arabia. She has an MMBS from the University of Khartoum. She also has a master in human clinical anatomy, and she is a research fellow at Michigan State University. So you are welcome, Dr. Rayyan, and you can start your case presentation.
Rayyan, you're muted.
Hello, everyone. Before I proceed, I'd like to thank you all for being here today, and I'd like to extend my heartfelt gratitude to all doctors and all professors for their invaluable support and guidance in advancing our knowledge. Today, I'll be presenting a case of locally advanced breast carcinoma, and this case highlights the challenges faced by the patient from the low socioeconomic background who often present with advanced disease due to the missed early screening. So let's dive into the details of this important case. Let me share my screen. Okay. So this case is 40 years old female presented with a palpable mass in her right breast. She first noticed the mass about 6 months before her presentation, but could not seek a medical evaluation due to her poor socioeconomic status, which restricted her access to the healthcare services. Over time, the mass gradually increased in size and was associated with intermittent pain. There were no changes in the skin or nipple discharge, but she reported feeling a lump in her right axilla. The patient is unmarried and has no family history of breast cancer. Upon evaluation of a triple assessment was performed, and including the clinical examination, the imaging studies, and biopsy to confirm the diagnosis. We will start with the imaging studies. Okay, so here we have the chest PA, which is basically clearly shows an irregular shaped dense mass-like lesion in the right breast. And here we have the chest CT, which is basically showed an 8 centimeter irregular shaped exophytic mass with the heterogeneous enhancement is seen in the right breast. And internal classification and necrotic portion are visible within the mass. There was no evidence of metastatic nodule in the both lung field, and a multiple metastatic lymph node are seen in the right axillary region. These findings are suggestive of local advanced fungating breast cancer. Now, in the ultrasound, also it was clear that there's a huge necrotic mass involving most of the right breast cancer, breast tissue, also be clear. And here in the PET CT, there is also a huge mass in the right breast with the FDG uptake. A few focal FDG uptakes in the right axillary level 1 region, and there is no other FDG uptake in the subspecies of the distant metastasis found too. Okay. So the pathological finding were the biopsy was confirming that it's an invasive ductal carcinoma, grade 3, and also the presence of the metastatic axillary lymph nodes. Now, locally advanced breast cancer is typically rare in developed countries thanks to the accessibility of routine breast cancer screening program. However, patients from the low socioeconomic background, such as this one, frequently miss this crucial screening due to the various barriers, including financial constraints and the lack of awareness. As a result, they often present with the more advanced stages of disease, which can complicate the treatment and worsen the outcome. This situation underscores the urgent need for the target intervention and to enhance the healthcare access and education of the underserved communities, ensuring that all women receive the timely care they deserve. Yeah, so in conclusion, addressing the healthcare access and early screening is crucial in reducing the incidence of locally advanced breast cancer, especially in underserved population. And thank you all for your attention.
Thank you, Dr. Ariane. Thank you very much. Arwa, are you here? Dr. Arwa? Okay. Dr. Khalid, you can proceed.
Okay, لحد ما أروى تجي, we can start the discussion. If any questions, comment to the three speakers, you're welcome. أروى ظهرت.
السلام عليكم.
عليكم السلام.
السلام
الحمد لله على
عليكم.
السلامة.
الله يسلمكم ويديكم العافية.
السلام.
أوكي.
الحقيقة أنا للأسف
الحمد
يعني
لله على
كان
السلامة يا روى.
الله يسلمكم يا رب. الحقيقة يعني نص الزمن كنت في الطيارة وفي المطار وكده، فيعني معلش كثير جدا، لكن الحمد لله إنه قدرت يعني تكاتي أب كده. ودكتورة نادية بخيرة ودكتور بابكر ما قصروا مع الباثولوجي، وأتمنى إنه يكون في يعني ناس من الجونيورز كده يقدروا النقاش المفيد ده. the floor is open for discussion. وشايفة معانا كمية من الأساتذة الممتازين المميزين، الدكتورة سلوى وكم زول أنا شفتها، لكن متذكر دكتورة سلوى. فإذا في زول عنده سؤال ولا كده تكتبوا لنا في الشات بوكس لحد ما السيشن ينتهي، إن شاء الله الناس تناقش كل الإجابات. شكرا جزيلا.
السلام عليكم. في ناس كثيرة رافعة يدها.
أيوة يا دكتور أروى، في ناس رافعين يديهم، ممكن تديهم فرصة يتكلموا.
أنا غايته رافع يدي وبعدين وحذرت وريتكم يعني فهبتدي أتكلم.
اتفضل.
تفضل
طيب
دكتور عمر،
ازيك؟
تفضل.
السلام عليكم.
يديك العافية.
بروفيسور نادية، بروفيسور سلوى, بروفيسور بابكر, thank you very much for this enlightening presentations. حقيقة استفدنا جدا جدا. طيب أنا my comment on Professor Babiker lecture, very useful. You mentioned that the one who have the HER2 positive patients, the one who had less than 10%, because I had just been in a conference for oncology conference, and the ISMO, they have two new trials in which they are testing new drug called AD, antibody drug conjugate, for the HER2 negative tumors. And they come to the conclusion that they're using this drug if the patient is not responding to chemotherapy, they go back to the pathology specimen and they reclassify it again, ask the pathologist to reclassify it again, and they come to say that even if it is less than 10%, you have to give us a percent, how much is it less than 10%? And even they reach a consensus that now that they can go to call it like low enriched or minimally enriched HER2, because in these two big trials, they are testing this drug in the patient who had metastatic disease or who is not responding to conventional chemotherapy. And they found very good result. And at the end of the trials now, they said that any patient who is reported negative, they should, in this trial, they should go back and report it as low enriched or minimum enriched. So I just want your opinion about this.
Thank you very much, Prof. Omar. It's very interesting, this new trial. As you know, all this fuss about HER2 is because of the cost. I remember when in about 20 years ago, it was only specific centers allowed to do the HER2. So we used to send our breast biopsies to these centers to assess it. And they were very firm, and they asked each lab to put the internal controls for 1+, 2+, and 3+. Now it is a bit looser. And I think there is an evidence, as I have said, even in some of the 1+ HER2 results, if the patient is one of the categories that I have mentioned, then now they go and give the anti-HER2 treatment. And I think it sounds logical for me. I mean, this trial, and that will give a wider access to bigger population of patients. It's just to feel sorry that in Sudan, I mean, even if they are 3+, I wonder if patient would have the treatment itself. But yes, I agree with you. This looks very interesting, and I will look forward to see the results of that when it is tested on a wider scale.
بس لو سمحت لي أعلق شوية على الموضوع ده. الكلام ده انترستنج يا دكتور عمر فعلا، لأنه حاليا في ضغط جديد على الانتيتي الجديدة دايرين يسموها ويعرفوها اسمها HER2 low. دي برضه جديدة، لأنه طبعا التريبل نيجاتيف عموما عامل ناس يعني دايرين بتاعت تريتمنت بتاعت الأونكولوجي ممكن يورونا أحسن، لكن حاليا فعلا الهيرتو لو بس يعمل جودة in different ways. أول حاجة بالسيريز أو بيعمل الستيني، وثاني حاجة عمل له بإنه هل يعني يعمل الموليكولر study for the ovary expression. Sometimes they correlate بين الجينيتيك بروفايل والإيمينوكيميكال بروفايل وكده. ففعلا هي حاجة very interesting و very new. Actually, إنه emerging entity of HER2 low expression. في دكتور نادية كلام شنو يا دكتور على الإجابة على السؤال. الشات بوكس كله تشكرات بالخير. بعد كده دكتور نادية ما ذكرته اديتونا حلقة أونلاين باثولوجي.
أروى ما سمعنا السؤال.
ما سامعك كويس والله.
السؤال لو سمحت يا أروى.
بتكلم لا بس قلت إنه الناس في الشات بوكس بيتكلموا عن يعني بيشكروا عن السيشنز وكده. كتر خيركم دكتورة نادية ودكتور بابكر، مثلتونا خير تمثيل. يعطيكم العافية.
Thank you very much, Arwa. That's my pleasure. Thank you.
كده مسموع؟
أيوة
السلام
كده
عليكم.
كويس يا أروى. أروى, it's good to hear your voice.
I can hear
Hello?
you, Arwa. Thank you very much for
صوت
compliment.
هنا مسموع؟
I'm very glad that this has been well received. Thank you very much.
السلام
عليكم.
عليكم أروى وكل الإخوة والأخوات الزملاء والزميلات. سعدت جدا بسمع أصواتكم بعد زمن طويل. Thank you for the presentation.
Thank you, Salwa.
دي دكتورة سلوى اللي اتكلمت دي.
سلوى، كيف حالك
هذه
دكتورة؟
دكتورة سلوى.
أيوة دكتورة سلوى.
دكتورة سلوى وينك انت يا هو قبضناكي.
في مصر أنا في القاهرة.
المفروض تكون بريزنتر معاكم.
إن شاء الله المرة الجاية.
رسلت لك لما فيكي. السلام ما صدقت إني سمعت صوتك.
أيوة كويس سمعت أصواتكم الليلة.
إن شاء الله. إن
الله
شاء الله.
يسلمك.
الله يكرمك.
إن شاء الله. الله يبارك فيك.
Sorry, I just want to add something. I think Nadia, she prompted me in her presentation about, if you allow me.
Yes, you can add.
Yeah, it's just about the regression scores that is used in our center. It's basically, I think Nadia, she uses the 3 score, 0, 1, and 2, or 1, 2, 3, I think, for which is fine for me. I think it's basically it is the same thing, but we use the Miller-Payne score, which is mainly regarding the regression. And interestingly enough, that grade 5, that no malignant cells are identifiable in sections from the site of the tumor. And then from 1 to 4, it's just going from worse to good, where 1 has there is no change, or there is no just some minor alteration on to tumor cells, but no reduction in the overall tumor. And we've got the measurement from the first the pre-treatment, pre-neoadjuvant, and the by radiology, and then we compare it with histology. Grade 2, there is minor loss of tumor cells, but overall cellularity is still high. And the cellularity loss is about 30%. So that's about 70% of the tumor is there. That is grade 2 in Miller-Payne. And grade 3 is between 30% and 90% reduction in the tumor cells. That means the remaining are either 70 to or 10 to 70%. That's grade 3. And grade 4, a marked disappearance of tumor cells such that only small clusters or widely dispersed individual cells remain, and more than 90% loss of tumor cells. And as I said, grade 5 is no malignant cells. So this is the Miller-Payne tumor regression score. For gastroenterology, we use the modified Ryan score. That is a different one, which is a 3-tier score. This one is 5-tier score. Thank you.
كنت عايزة أعلق على الكلام يا دكتور بابكر لو تسمحي. في نقطة مهمة جدا أنا بالنسبة لي دائما تشكل أهمية بالنسبة للباثولوجيست عموما، إنه الليميتيشنز بتاعت البيوبسي، إنه في النهاية الباثولوجيست ما في يده غير البيوبسي. في النهاية يعني في أناليتكس اللي هي الكولد سكيميا تايم ده لا دكتور بابكر واتكلمت عنها نادية، مهمة جدا وأساسية في تحديد الجروس أبيرنس بتاع التيومر اريا، وتحديد البوزيتيفيتي والنيجاتيفيتي حق معظم البروجنوستيك ماركرز الباي ماركرز كده. فالموضوع بتاع البري اناليتكس حتى حكاية هير لو، يعني زي ما قال لنا دكتور عمر الفاروق إنه بيقولوا للباثولوجيست ريبيت، ده كلام صح، لأنه يعني sometimes إنه البري اناليتكس أو التويس اوف ذا تيشو هو ممكن يأثر على إنه الهير 2 ده هو لو ولا نيجاتيف خالص ولا حاصل. فالبري اناليتكس في الباثولوجي صراحة مهم شديد، لأنه الباثولوجيست is really limited by the biopsy or the material that they have got in the lab, يعني received in the lab. And the radiologists and the clinicians are actually our eyes and ears. كمان إحنا we deliver back للoncologist to be our hands and feet عشان بيتصرف مع العيان. فإذا نحن ما بقينا كلنا collaborative working مع بعض حقيقي يعني الكير بيكون ناقص كده. فأفتكر إنه this session is really one example for this collaborative.
Thank you very much, Dr. Arwa. I agree with you that pathology has got limitations, but our role as pathologists to minimize these limitations to the minimum. And in most of the places where I have practiced histopathology and cytopathology, there are measures used to lower these limitations of pathology. One of them is the external quality control. That's most of the laboratories to be recognized. They should be participant in external quality control. And as I have said earlier, regarding ER, PR, and HER2, all these prognostic markers that with consequences of expensive treatment, there are some, external quality programs that to assess the labs, and you should achieve about 95% concordance with approved laboratory. This is one of the things, and the other thing that we use to minimize the errors and the maximize the utility of histopathology as a diagnostic tool. And the histopathology, by the way, is one of the cheapest diagnostic tools. I mean, this glass H&E slide is just about 15p or 50p, not more than that. And then we achieve with it a lot of things, and we give diagnoses, we give prognostic markers. So the pathology is a very essential and very central component of the diagnostic blocks. But as I said, by external quality assurance, participation in these quality assurance programs, by using good reagents from very reliable companies, by using very good tools and equipment, by having very good technicians and biomedical scientists who could do thin sections and could minimize the errors and all the artifacts that we are having, in the stain, the formalin pigment and all the errors that could lead you not to give a meaningful result. And also, most important thing is to have protocols. We have standard operating procedures, and that should be standardized among each department. Very sad. I listened to these presentations about radiology. I think the first speaker, Dr. Sarah, I can't remember the name very well, but she just presented all the guidelines from different, different institutions, American, British, etc. We should have our national guidelines, and that according to our conditions, and then we should follow that, and we should inspect this, and we should make sure that there is a good quality program. There is a sticking to our standard operating procedures. One of the important factors that minimize also mistake errors and improve the quality of pathology is the audit. The pathology audit, that we audit our work and we try to identify the poor performance, and we support our colleagues to achieve higher performance rate. So there are a lot of issues that, a lot of factors that we could use and implement in pathology so that we could have good output of pathology service. Thank you.
Thank you, Dr. Babiker, and thank you, Dr. Nadia DR. Very interesting and very elaborated presentation. Dr. Nadia, I enjoyed very much your slides and the response after chemotherapy. My question is, do we have any trials of neoadjuvant trastuzumab in Sudan? Because in the recent studies now, they are talking about neoadjuvant trastuzumab. So I would like to know, Dr. Nadia, your slides were only after chemotherapy, or you have some experience of the use of neoadjuvant trastuzumab because it's changed the prognosis of the disease very much. Welcome, Dr. Salwa. We missed you. And Dr. Arwa, alhamdulillah, salam.
أهلا بك مس عايدة، يعطيك العافية. دكتورة نادية تفضلي تجاوبي على السؤال لو سمحتي.
Yes, thank you, Aida. It's good to hear your voice again. I can only, we usually don't have any information about how the, and sometimes we only discover later from the co-patients that
دكتورة نادية الصوت يا دكتورة نادية ما واضح.
Okay. Is it better like this?
معلش وحاول أظهر كاميرا عشان التوثيق، لما أي حد لو بيسأل ولا بيجاوب لو ظهر بالكاميرا لتوثيق السيمبوزيوم ده وكده. شكرا لكم.
Usually, is the sound better like this? Hello?
أيوة أحسن شوية.
Yes, we can hear you now.
Okay. Usually, we don't have the information. Sometimes we only discover or we realize that this patient had neoadjuvant chemotherapy when we start opening the sample. And I cannot tell you exactly, I cannot answer your question.
Thank you so much.
معلش مس عايدة. Actually في البرزنتيشن حق الدكتورة نادية they mentioned هي ذاتها she mentioned أفتكر الحتة حقت neoadjuvant therapy. يعني في الأول كانوا بيتكلموا عن الريسبونس pathological response after neoadjuvant chemotherapy، لكن now في النهاية هي قالت في السلايدز لو بتتذكروا إنه nowadays بقى neoadjuvant therapy in general، لأنه sometimes بيكون trastuzumab. لكن ما عارفة يا دكتورة نادية إذا صححيني إذا غلط.
لا, it's true. I had to differentiate between the two, but mainly my presentation was chemotherapy.
I know
That's
about
why I had received. Yes, but now
عايدة كلامها عن in general neoadjuvant therapy like everything، حتى إذا كان chemotherapy أو something
yes, we
else.
have to take part of all of it. I have no idea what is happening in Sudan, so I cannot tell you. I really don't have, we hardly get the information sometimes that actually these patients received treatment before they came to us, regardless of what type of treatment.
Even we had a trial of neoadjuvant hormonal therapy. So
yes.
we had some ladies who presented late with estrogen receptors positive tumors, and we started giving them hormonal therapy with Dr. Ahmed Al-Haj, and the lady responded very well. She responded very well to the hormonal therapy to the extent that she was asking, do I need a surgery or not? So that's why I am asking,
Yeah, but I cannot say for sure. And histologically, Babiker, what is the difference? Do you have an idea?
I think most of the regression and all the post neoadjuvant chemotherapy treatment is based, as you said, on chemotherapy, and this is easily identifiable. I haven't seen yet a case where the patient has received tamoxifen therapy alone and then as a neoadjuvant mode of treatment and then looked into. I'm not, I haven't seen it. It could be done somewhere else, but this is not the practice that is routinely done in where I have worked. Mainly it is chemotherapy. Maybe these are trials at the moment. I don't know whether either where these trials or where this is just practices in Sudan or whether these are also.
No, it's acknowledged practice. It's not just in Sudan.
I have no any experience with that. Mainly it's very easy to assess the chemotherapy because as Nadia shown you, that there are a lot of changes on cells. There is a lot of fibrosis, neovascularization, macrophages, and the tumor bed is very clear. I haven't seen a tumor bed yet with tamoxifen treatment only, so I cannot judge you on that.
Thank you, Dr. Babiker. This is in Sudan. In fact, I have two patients. One now still she didn't have the surgery yet, and the first one after she completed the neoadjuvant hormonal therapy, we did the surgery for her. She survived, I think, for 5 years. So this was in Sudan.
Very interesting. Yeah.
And was it a proven breast cancer? I mean, was it
Yeah.
100%?
Yeah, it was locally advanced. It was locally advanced, and all my cases I used to do through cut needle biopsy, and even the tumor markers, the immunohistochemistry, and everything. And I used to do staging. So it's
very
proven by,
interesting.
yeah.
It's very interesting, and must be luminal A tumors.
Yes, of course, yes.
شكرا جزيلا. دكتورة سلوى رافعة يدها. تفضلي دكتورة سلوى.
شكرا جزيلا. شكرا دكتورة عايدة for your compliment. Just an addition لدكتور Babiker, thank you for raising an issue of having standardized reporting SOPs as well as having national guidelines. Actually, these guidelines, there are a lot of guidelines written and endorsed to the Ministry of Health.
But not
implemented actually.
As usual.
And we share with other colleagues in writing these guidelines or protocols, but not endorsed at all. It is there, sitting there in the inside actually the Ministry of Health، لكن للأسف الحكاية دي ما اتطبقت. وأنا أفتكر يعني unfortunately بس الأوضاع في السودان now not favorable, but يعني it is high time for collaborative work. دي حاجة مهمة جدا جدا، لأنه this is for the benefit of the patient, and we hope إنه السودان يرجع يعني ونقدر نعمل يعني ونشتغل في هذا المسار وكده عشان for the benefit of the patient إن شاء الله.
إن شاء الله.
Thank you so much.
Moreover, Dr. Salwa, these guidelines has been done 2006 at Jazeera.
أيوة نحن حضرناها كلها.
Yes, and it has been updated 2010 at Khartoum.
Yes.
And we were preparing for update. And the first two editions, they were not including radiology. But we have a draft of the radiology done by Dr. Wishah and Dr. Reem Mohammed. And all the group of the radiologists, we have a draft for the guidelines for the management of breast cancer radiology, and it's not had been completed. Moreover, we are working on a national strategy for the management of the breast cancer, and all the drafts were done, and it was about to be endorsed, but
unfortunately. أيوة.
Yeah, and the other point
with both of you, I think it is high time that we move forward with our practice, not only in breast cancer,
in
all diseases. We should have standardized protocols. I think the Sudanese Medical Specialization Board should take a role here, the Sudanese Medical Council, the Ministry of Health.
Yeah.
We've got a lot of issues. I mean, the reversed pyramid with a lot of private centers and little government centers providing the service. Hopefully after the war إن شاء الله بعد حرب الكرامة that things will improve.
إن شاء الله الأمور تتصلح بإذن الله. We all hope for the best.
Yeah, we hope for the best. But the interesting thing is that the program you mentioned, Aida and Silwa, and we were all involved, is that it is based on something that has been tried out in our country. This is the thing, that it's not, we are not importing something. Of course, it's based on international guidelines, but actually it was practiced in Jazeera. So it is based on the Jazeera program, and we can, it's a practice national program. This is the good thing about it.
Yes, Dr. Nadia, it was started in Jazeera 2006, but it's updated in Khartoum 2010. And
Yeah,
we were,
but they, but
we were working.
in Jazeera, they were already using, they are using it actually.
Yes, yes. We in our breast clinic in Khartoum, we were using the protocol in our breast
exactly.
clinic. Yeah,
yeah, the little booklet. Yes,
but we are aiming to use all over the Sudan. Yeah, our aim.
And I think another point that I'd like to bring up, because it's something that we need to think about and decide nationwide, is the use of in all aspects. It is something that has faced us in the laboratory, and that is that we are originally based British, but like I saw it now also Babiker talking.
الصوت يا دكتورة نادية بعيد بقى.
No, it's the same thing. British system. We all started, at least the older people, we started with the British system. So we are like Royal College. And Babiker, I think because you worked there, you are the same. But then you are confronted now by the American. All the young people, they want American system. So which one do we join? Or do we make our own? And I think my people, they know that I am interested in the Euro-Asian, because it's a combination of the Royal and the American. And that one is much more easier to apply in our country. So this conflict, it needs really to be decided. Of course, we need to, we can also, like I saw now the radiologists, the young ones, they showed everyone, every scheme. And then we need to make our own out of that we can apply and follow in Sudan.
I just want to mention a little story that Arwa might remember. In 2019, I was working in SOBA at that time, and she consulted me about skin biopsy. And I gave her my opinion, and then I'm just remembering this because I saw it in my WhatsApp, and then I asked her whether there is an adequate immunomarkers to assess this, and she said adequate with the standard of Sudan. So I'm not favoring to follow any American or British. I work in British system for about 18 or 20 years. And now I am working in an American system in the Gulf. They use the American, and our lab actually now is seeking the College of American Pathologists accreditation. It is already accredited by JCI and all these things. I'm favoring to use our national things. For instance, we don't have a lot of resources in Sudan, and the patients are paying out of pockets. I don't want to charge patient for about 10 markers that I use normally when I want to assess breast or a metastatic lymph node biopsy. I need to know whether the patient is a breast carcinoma. I need to know whether this is a breast or not. So I will just use one marker. I will just use GATA3, for instance. So we have to adopt a local thing that suits our resources, that suits the way that we need, and easy to implement. Because these guidelines have got medical legal implications. If you go to the court, then if these guidelines are implemented and endorsed, you have to follow them. And if you don't follow them, then you will be incriminated. So I don't want to use guidelines that are used in USA. I cannot implement that, or in UK. I will see the thing that I could achieve here in Sudan, and then I will put preferable, if the resources allow, I will put use this, use that, use this. But I wouldn't make guidelines so that I take 50% of my pathologists to the court because they didn't use this immuno, they didn't use that molecular testing, etc. So we need to be realistic, I think, and all pathologists, oncologists, surgeons, clinicians, they should sit together and see what are the reasonable requirements for managing and diagnosing breast cancers. And then to take that to Ministry of Health to endorse it, then to take it to the parliament so that it becomes like a law. So then the women groups, we've got very active women groups like your groups here, they can even advocate for that. And then you recognize the labs. This is a certified breast cancer laboratory or radiology, etc. Because Dr. Merritt also said previously that most of the radiology tests, the ultrasound is done by someone, CT by another one, MRI by a third one, and this is a very patchy sort of service. So we should encourage and promote the model that I have seen, the breast cancer screening center in Marat, where I'm sure now it is occupied by someone, or a qanasa or a sniper is sitting there. But I think that is the best approach, and we have to propagate that. At least each head of state should have a similar center like this, and it should be resourced by the Ministry of Health, because the breast cancer is one of the widest breast cancers among women, up to 25% of the mortality, and can be due to this breast cancers in women with cancers. So it is very important that we do the guidelines, but we should do them wisely. We should do them within our limitation and budget, and not only that, we have to know how to implement them and how to make it a law, and how to make it a certified thing, and to introduce the external quality programs, and people who are involved in reporting breast pathology should be part of that. People who are involved in breast radiology should be part of that. So all these issues are important, but the doctors, clinicians, and also the beneficiaries and patient groups should sit together to implement these guidelines and to take them further.
I definitely agree, Babiker. And I'm not asking to follow immediately, religiously, the American or the British or the Euro-Asian, but we need one of them base it on, because we cannot go that far with all the steps, but you need a framework on which to work.
Yeah, I agree with you. Thank you very much.
For sure, we are not going to other countries' guidelines, because we had our base guidelines, and we hope in New Sudan that the patients are not going to have the investigations out of their pocket. We hope everything is going to change soon. We hope. Let us hope.
Inshallah, inshallah.
We all hope for that.
Inshallah, inshallah.
شكرا لكم
السلام.
كثير يا جماعة.
الهوب يا دكتورة عايدة محتاج تصحبوا أشياء تانية. إن شاء الله، نقول إن شاء الله.
ايوه ما عندنا غير الامل يا دكتوره رباب، ما عندنا بندقيه نشيلها زي الناس اللي عندهم بنادق، ما عندنا غير الامل والكلمه بنحارب بها.
وهي الكلمه دي ما خلاص، دي ما هي الكلمه
أيوة. سلاحنا هو الكلمه بس، لكن
أيوة.
ما عندنا بندقيه ولا عندنا دبابه ولا عندنا طياره ولا عندنا اي حاجه.
بعد adding to this نحن مفروض to be prepared نفسيا، يعني what we will do لما نرجع، دي حاجة مهمة جدا. لكن لما نقعد ننتظر لما نرجع بعدين حنفكر، لا.
You are right.
This is not the way. أيوة.
عشان كده إن شاء الله قبل ما ديل يختموا البرنامج بتاع جمعيتنا حيكون monthly إن شاء الله. حتكون في لكشر كل سبت من أول سبت في كل شهر، وإن شاء الله السبت الجاي حيكون بداية نوفمبر دكتورة نادية حتقدم لنا محاضرة عن في الباثولوجي، وحتكون ريجولر باثولوجي، سيرجري، اونكولوجي، راديولوجي، وهكذا. واتمنى نفس الجروب ده كله يعني يستمر ويشاركنا، يعني ما تغادروا الجروب بتاع السيمبوزيوم بحيث انه النشاط يستمر ان شاء الله.
إن شاء الله.
oncology
ربنا يوفق، ربنا
I
يوفق.
think
أيوة.
for your organization, Dr. Rabab, for next year symposium to be on the guidelines for breast cancer management.
national guidelines.
Yes.
تمام جدا. ايوه واي نوت.
معلش يا جماعة عايزة أنبهكم
المقترحات
للفورم.
هتنزل في الجروب يا دكتور، بس بعد ما ينتهي السيمبوزيوم الناس ما تغادروا بحيث انه يكون نواة للاكتيفيتيز
إن شاء الله.
ان
هسه
شاء
يا
الله.
دكتورة رباب في حاجة مهمة، الفورم بتاع الاي ايكو عشان الصفحة حقتنا تفضل قاعدة وفيها الريسورسز حقتنا. الفورم ده لازم نملاه كلنا، البارتيسيبانتس والسبيكرز وكل الناس. الفورم قاعد في الشات رسلته لنا.
لو تسمح لي يا دكتور أروى. I want to
اتفضلي.
thank you all of our speaker for today. I am Rayhan Abdulwahab, the coordinator from SIDRO. بس عايزة أشكر كل السبيكر، والنقاش البناء في نهاية السيشنز كان ألطف حاجة. دكتور بابكر، دكتورة عايدة، دكتورة نادية، دكتورة سلوى، كلكم. بس أنا عايزة بس زي ما قالت دكتورة أروى أنبهكم إنه هنا عندنا فيدباك. كل اقتراحاتكم ممكن تكتبوها فيه، وإحنا دائما بنرجع للفيدباك عشان السنة الجاية وعشان المرات الجاية والسيشن الجاية. لو عندكم أي اقتراحات بلس فيه زي كويشن بسيطة عن إنه الفائدة طلعوا بها كل الناس من السيشن الليلة، ففيه زي كويشنز بسيطة، فلو ممكن ترجعوا له. أنا خدت اللينك في الكومنت، فبس اتأكدوا كلكم إنكم you go through it قبل تطلعوا إن شاء الله. over to you دكتور عروة.
لو رسلتيه برضه في جروب الواتساب يكون أحسن
جدا يا
لو
دكتور.
الناس اللي
حارسين.
ما قدروا يحضروا لحد النهاية حيبقوا في جروب الواتساب.
أنا
Yes, of
طبعا
course.
مشترك في جروب الواتساب، بس I don't know about the other groups يعني.
الجروب السيمبوزيوم I will send it.
تمام يا جماعة. خلاص خلصنا.
مرحبا ريان، معلش دكتور خالد.
تفضلي.
لا بس برحب بريان بنتي، قلت لها مرحبا.
مرحبا بك انت برضه. بكره ان شاء الله، بكره tomorrow will be a marathonic day. It will start at 9 a.m. Sudan local time and will end on it will end at 4 p.m. right?
أيوة إن شاء الله هنبدأ 9 شارب
خلاص.
بتوقيت السودان، 10 بتوقيت مصر، 12 بتوقيت 12 دول بتوقيت الإمارات إن شاء الله.
12 ولا 11؟
I think it is 12. فرقكم من السودان ساعتين. أيوة 11 معلش. يس 11.
نحن عمان
مقلب
12.
مستر عمر الفاروق.
يس إن شاء الله.
صح يا ريان كلامك صح، يعني إذا بيع مش كده؟
يا
10
ريان
بتوقيت السعودية معناها هو مصر مش كده، و11
أيوة.
في توقيت الإمارات.
مستر عمر
أيوة
حتقدم
بالضبط.
الله.
أنا هقدم في الأول بس
أيوة.
عشان أنا بكرة شغال.
إن شاء
أيوة
الله يا
إن شاء
دكتور.
الله. هاي حتقدم في الأول. أيوة
إذا
حتقدم
ممكن
أول حاجة.
أيوة إن شاء
الساعة
الله يا دكتور.
11.
نعم الساعة 11.
أيوة كويس.
قبل السيشن بنص ساعة بنرسل اللينك إن شاء الله.
أنا رسلت لك في الجروب أكشوال.
أوكي
رسلت لك
تمام
في الواتساب صوت.
تمام.
خلاص نختم بأبيات يا جماعة.
أيوة ادينا الأبيات.
وطننا باسمك كتبنا ورطنا، أحبك مكانك صميم الفؤاد، باسمك أغني وتغني السواقي، خيوط الطواقي سلام التلاقي ودموع الفراق، وأحبك ملاذ وناسك عزاز، أحبك حقيقة أحبك مجاز. شكرا لكم يا جماعة وتصبحوا على خير.
سلام. القصائد الوطنية دي يا دكتور خالد تطرق القلب تماما يعني.
اي والله.
شكرا دكتور بابكر.
لازم حنرجع لوطننا وبلدنا إن شاء الله ونعمر من جديد.
إن شاء
إن شاء
الله.
الله إن شاء
شكرا
الله.
يلا
لكم.
تصبحوا على خير. السلام عليكم.
اللهم
وعليكم
امين.
السلام.
عليكم السلام. عليكم السلام.
نلتقي بكرة إن شاء الله. السلام عليكم.